Hey everyone, good evening. My name is Chris Holsinger. It's a real pleasure to welcome everybody from around the country and world to this evening's American Head and Neck Society TORS webinar series. I'm Chris Holsinger. I'm head and neck surgeon at Stanford, and I'm very pleased to introduce Ryan Lee and Katie Van Abel, who are our amazing moderators who are going to introduce our great panelists. And I'm really excited about tonight's event. I do want to acknowledge and thank the generous educational gift provided by Intuitive Surgical for the support of this. And with that, I'm going to turn it over to Ryan and Katie for a great hour. TORS, alphabet soup from SI to SP and beyond. Thank you all.
Thank you, Chris. And thanks for everybody else joining on here today. We've got four great faculty and Dr. Van Abel as a moderator, so four panelists from various programs throughout the country. Dr. Ryan Jackson hails from WashU in St. Louis. Dr. Oluwafumi Lola resides in Las Vegas. She's at University of Nevada there. Dr. Brittany Barber at the University of Washington in Seattle. And Dr. Brian Sumer is a professor at UT Southwestern in Texas. And we're welcoming all of them here. Thank you guys for chiming in. This is meant to be a really rapid fire talk through of various tips and tricks and lessons learned in adopting the SP system over the past couple of years. And so again, thank you for coming. And Katie, why don't you take it away?
Awesome. So I'm going to start with a very brief history of transoral robotic surgery, just so we can get a kind of a sense of where we are and how we got here. The very first time the word robot was used was back in 1920 when Karel Čapek, who was a Czech playwright, wrote the Ransom's Universal Robots play and used the word robot, which was a Czech word for forced labor, and introduced that into our society. In the early 2000s, doctors O'Malley, Weinstein, and Hochstein were really starting their investigations into transoral robotic surgery. And in 2006, they did the first in-human TORS surgery for supraglottic and base of tongue patients, and were able to publish that as a first clinical trial. In 2009, the SI received FDA approval for a T1 and T2 oral cavity, pharyngeal, laryngeal, and benign disease. And then it's been a little while. So from 2009 to 2019, we were all getting really used to the SI. A few of us started using the XI a little bit. And then in 2019, the SP came around, which is our single port robot from Da Vinci, Intuitive Surgical, and that was FDA approved. Now, there have been some other robots that have been, on the market or have entered the market, and we by no means are saying that the intuitive robot is the only one to be used, but it's really the one that we associate with transoral robotic surgery at this point. So we're going to spend the majority of this hour answering questions about how we go from this period of time between 2009 and 2019 when we all got really used to our SI, and now we're making this transition to the SP. It's not the same car with a new paint job. It really is a different device. And so we all have gone through the process of getting used to this new device and wanted to share a few tips and tricks that we've learned along the way. So we're going to do this in a question and answer format. The first three questions we're going to ask to our entire panel. The remainder of the questions we're going to ask to specific panelists, and then invite some additional questions. As we go along, Dr. Holsinger will be watching the Q&A. So if you have questions, go ahead and put them in there. We'll either answer them as we go or we'll answer them at the end.
Okay, first off the bat, and this is a question actually for all of the panelists. If you can articulate 2 or 3 important skills that you felt you needed to adopt in order to become more facile with the SP. I'm just going to go from left to right on my screen. Ryan Jackson, Dr. Jackson, can you go first?
Yeah, I think the most important skill I had to learn, at least transitioning from the SI system or even the XI system, is I couldn't make big movements anymore. I operated very large with the other systems. I moved my elbows a lot to create lateral and vertical movements. You can't do that with the SP. You really have to work with your fingertips and use the wrist of your arm and the wrist of the instruments to make a good movement. So I think that's probably the most important skill I had to adapt. And then using them in a 3-dimensional space was very important. So with the SI system and the XI system, everything comes in straight instruments with tips that work up or down or to the side. So you're really only working more two-dimensionally in a three-dimensionally space. But with this, the instruments have to, deploy inside of the mouth to be able to function properly. So I had to master how to position the elbow so it wasn't colliding with the jaw, the retractor, or the camera, or the other instruments behind my view, because the prior systems, everything behind your view really wasn't colliding with anything. It was impossible. That's probably the two most important things I had to adapt to.
Good. Yeah, I think that's probably going to be across the board, a pretty common theme. Yeah. How about Dr. Oluwafumilola?
Thank you, Ryan. So I would say that when I think about skills to master for the SP, I sort of looked at it from the standpoint of whether the patient side training or looking at the console training. And I think being able to look at those in terms of technical also versus non-technical skills, because I think those different aspects impact on your learning. So if we look at, the console training aspect and you're looking at the technical skills, I think being able to, as a surgeon, just like Dr. Jackson was saying, being able to coordinate, the camera now, which is now, endo-wristed, with your pedal and your finger wrist movements to essentially achieve what you want without, again, colliding proximally within the cannula that you're operating in. And then, if we think about the patient side training, I think knowing that you just have one port now, and I think for sure, whoever is, helping to work as an assistant, I think they definitely appreciate the fact that they don't have to try to dock anymore to avoid multiple arms in the way. But I think also learning to work with that single port becomes a critical component of transitioning from having a lot of white space to a much smaller space now and a shorter and a distance to walk to the patient.
No, it's really good. Yeah, collisions are always the kind of the hardest things to try to figure out. Why are they happening? Why are they frequent early on? Dr. Barber, can I get your 2 cents?
Thank you, Ryan. Yeah, I would say, of course, we're probably going to say a lot of the same things here. So I would echo what's been said previously, but I would say also probably using the palatal fossa a little bit more than previous, because you have that three-dimensional space, and using the Cobra pose, which I think we're going to talk about a little bit more. I guess I'd also say I had to get used to looking at the navigator and making use of it, because it is an advantage to have it. So I'd say that as well. And then I would certainly echo the comments about the wrists and elbow movements. So certainly making a lot smaller movements in the mouth and trying to be cognizant of running into the molars. Yeah, all those things.
All right, thank you. And then Dr. Sumer.
So I think I echo everybody else. I think the analogy that I always use when I'm describing this, the first few times that I did the SP robot, it felt like I was transplanting my brain into the body of an octopus, because now you have elbows and wrists and you have an extra arm in there and everything's kind of moving around, and the arm tangle becomes like a real issue, as everyone else has pointed out. The other thing that I do like is that navigation pane on the bottom, as Dr. Barber's pointed out. But it's not just the arms. It's also the little squares around your devices that you're activating. And one of the things that I had to get used to was the fact that you can have multiple instruments that are electrifiable in the oropharynx. And I'm super paranoid about an airway fire. So now you have a monopolar cautery, you have a bipolar, maybe even 2 bipolars. So hovering over the pedals kind of lights up that blue square around the instrument you're about to activate. And that's always like a good final safety check before you activate something, because now you're using 2 sets of pedals with potentially 2 or more sets of electrifiable instruments. So that is an important skill, is to really use that navigator pane on the bottom. And the analogy for that is if you're a pilot, it's like instrument flying versus visual flying. So if you're in a Cessna, you use your visual cues to fly, but if you're in a big 787, a modern plane, you have to get used to using the modern devices, and that navigator, including the blue squares around your instruments, are the modern devices you have to use for the SP.
This is beautiful. Palatal fossa to the lighted squares. I love it. Ryan, I just wanted to interject. We have our first question from Vikas Mehta.
All right. Do you have it read out
here? I do not have that. Vikas, I'm going to reach out to you. We're going to get that. I don't see that in the chat. Why don't you add that in the Q&A? We see your hand, but use the chat function, and we'll come back to him in a minute.
Perfect. Okay, thank you. All right, Dr. Van Abel, you want to chime in here, or do you want to keep moving on and add on in the
I
next
think
slide?
let's keep moving on. We've got a lot
Okay.
of really great things to cover. I think I could go on about this for a little while. So, all right. I think that we probably covered a little bit of this, but instead of focusing on what were the things that you really came away with your new access to the SP as things you learned, what were the biggest challenges in adopting the system? We heard from Baran is like you became an octopus, but what were some of the biggest challenges? Fumi, what do you think?
For me, I think initially, before the new cover pose button was now made available automatic, I think one of the biggest challenges was learning how to do the cover pose, because it does offer a significant advantage, having that overhead view away from your instruments, where you have to work, you're not like working in plane, but you're working out of plane, but over. But trying to get it to where you want it and knowing that you're actually there became a little bit of a challenge for starting. I mean, now there's the button, but before, you have to work on clicking on the endoscope pedal, selecting, the camera mode, moving your elbow away from the instruments, and then raising your wrist up, flexing your wrist down, and then being able to make sure that you're aligned before it then turns green and then tells you that you're good to go. Now it's all in 5 seconds, so it's much better now. But I think that was probably my biggest challenge, one of my biggest challenges, transitioning to the SP.
How about Ryan Jackson?
I think the internal collisions, I think, is most people's first biggest challenge, because we're not used to the three-dimensional space. I really had to learn how the engineers designed the system to actually use it right. And I really never figured it out until I realized how they wanted this designed. And they wanted the elbows of the instruments as far away as possible, even though that might not be, 120 degrees apart. If you have 3 instruments like this, if you're doing a tongue base, you still need them as far away as possible to get as much mobility. The second thing that I think was really challenging was using your assistant, because trying to get instruments through this three-dimensional space, because everything's coming out of a single port and then deploying open and aiming back toward your target, applying clips and getting a suction in there was challenging at first. I remember the first time I had a bleeding event, the fellow was trying to get a clip on and couldn't. And I was sitting there like, what the heck is going on? 30 seconds went by. I'm like, this is silly. What is going on? And I get up from the console and I go look, and I'm like, oh gosh, this is hard. I can't get the clip in there either. And then you got to realize you got to pull one of the instruments back a little bit to straighten it to get the clip in. So I think that was one of the biggest challenges, is utilizing the assistant at the very beginning.
Brittany?
Yeah, I would say both those things. I think the elbows versus wrists learning curve, certainly the bigger camera, and so the instrument collisions that came with that, and the assistant access, and then positioning the camera in kind of like a narrow palette patient was, I think, also a little bit challenging. But like I said, once you get used to the three-dimensional construct, I think those challenges can be mitigated.
And Baran?
Yeah, I would say the assistants, because they have less room, as Ryan pointed out. The first time I actually went to the bedside and assisted my fellow as the first assist, I was struck by just how difficult it was to help. And then a lot of times you can only get one suction in there. So I think that's the most challenging thing. And then the overhead, boom is kind of in the way a little bit, depending on the positioning. So I would say that's the biggest challenge.
For me, one of the things was realizing that I had to watch my view change as my instruments started to deflect on my camera. That wasn't an input that I was used to paying attention to. And so now, being able to recognize, oh, I don't want to keep making that move, or I'm going to skip over the top. I need to stop and readjust, either clutch out laterally or adjust up at the head. That was something that took a little time for me. Let's see, next question.
Okay, so because we all adopted this new system a few years ago, or in the last year, we'd love to hear from the panelists. What are your favorite functions that you find, particularly new functions on this system compared to any prior platform that you've used? So I'm going to go again with Dr. Jackson.
I'm sorry, I was responding to Chris's text here. What was the question?
That's okay.
Chris is hammer
So the
texting all of us.
The question is, what would you say are your favorite functions? Maybe just pick one or two with the new SP system that you think is a new functionality over a previous system that you've used, which presumably was the
Yeah.
SI.
I'm lucky to be the first one because I think a lot of people are going to have the same one because those of us that use the SI platform always wanted a bipolar. One of the things I lost with this is the clip applier. I used to put the 8mm clip in a port for the SI system. So that kind of got around that, and I used the bayonet bipolar, but having the bipolar built into the Maryland is pretty helpful in my experience. It saves probably 5 to 10 minutes each case. It gets me out of some trouble every once in a while before I can apply a clip. So I think the bipolar is my favorite.
We could save some time and say, everybody raise your hand if it's the bipolar. Would definitely be mine.
Yep, we would all have just paid for a bipolar, right? All right. Dr. Barber, you have any other favorite functions?
Yeah, so I mean, I love the bipolar. I think that's huge. I think a couple other things. I think I don't use the third arm a whole lot, but if you have a really inexperienced trainee and you're doing a basic tongue resection, then I will sometimes use it just to kind of obviate all of the moving around that can occur otherwise. And I also like that. I think there are less external collisions if you set up things appropriately. So I like those things. And then I think there's a lot less setup time in my hands anyways, just because of how it's deployed. So.
In mind too, parking that is way easier than with the SI, right? Dr. Sumer.
I like the bipolar, but I even like the fact that you can adjust it from the console even more, because a lot of times, your circulator may be out of the room and you're asking them to turn the bipolar or bovie up or down or switch chords and things like that. And you can make those adjustments on the fly right at the console. And it gives you a lot more flexibility. So you can use, auto cut, for example, on a very, very low setting to make very fine mucosal cuts. I go all the way down to 1. You can turn it up if you want to cauterize a big vessel on the bipolar. So just having the ability to change those settings on the fly makes you realize that you actually want to change those settings on the fly, but you just don't want to spend 2 minutes or 3 minutes doing that. Now that you can do it from the console, you don't have to.
Good, thank you. And it looks like Dr. Jackson is answering some questions on the chat. So there's a Q&A, just as a reminder, Q&A function on this WebEx as well as a chat function. It looks like everybody has access to both right now, which is great. So you guys can look at the interesting questions that are relevant to what we're talking about. But I haven't forgotten Dr. Oluwafumilola. Why don't you share one or two of your favorite functions for the new system?
I would say, I think the bipolar definitely was a significant advantage for operating. I do like clips, and so I do have a nice clip applier, but I think for all the reasons we discussed earlier, having that Maryland bipolar is definitely an advantage. But I think also in the rare situation or rare case, that knowing you have the ability to switch your camera views, I think, going from camera above to camera below, I think there are unique situations where that does come in handy. And like, especially if you're transversing, one subside to the other. I remember I found it helpful when I was doing a case that involved, posterior pharyngeal lipoma excision, and being able to transition from, the standard camera above view for the oropharyngeal aspect, and then trying to get the tip of it that was towards the inferior nasopharynx, being able to switch my camera around to get to that view was also an advantage.
Yeah, I agree. I was going to just tack on there, the image quality of the new camera, the image fidelity is so much improved compared to the SI system, right? And having some good zoom functions too is found useful, and the autofocus as well. All right, let's keep moving on.
Well, this is kind of perfect because some of the questions in the chat relate directly to Dr. Baran's or Dr. Sumer's video here. So do you want to kind of talk us through that and what settings you're putting it at? And
yeah, I mean, this is exactly what I was talking about. So these are the energy settings. This is what it looks like at the console. You can adjust this up or down. Obviously these aren't your traditional bipolar cautery settings that you're used to. They go from, in this case, I think 1 to 9-ish, 9. And it changes depending on what you're using versus, cut versus coag. And then you see me here just grabbing a vessel and cauterizing it and temporizing the bleeding. In the olden days, this would be very stressful because you'd be trying to get a clip on it, and that would be the only option you'd have for stopping the bleeding. But now you can actually bipolar it and stop the bleeding, and then deal with it without the pharynx filling up with blood. So it actually really decreases the stress level in the operating room. This is a good demonstration of that.
And then this is a demonstration of your elbows and wrists.
Right. So remember, you now have elbows, right? You don't just have wrists. This is us clipping a vessel here. But what you'll see is you see this endotracheal tube kind of getting in the way. And what you can do is actually you can elbow it out of the way. So the way I describe this is pretend you're in the New York subway and you're trying to get out of the car and people are in your way and you're just kind of everyone's elbowing each other out of the way. And that's what I do here with the endotracheal tube. And that allows you to, number one, keep that third arm, the wrist in there so you can use your third arm. But now you've elbowed it out of your way with the kind of the guarded part of your instrument. So you're not going to burn it. The one other thing that I always do is keep the cutiere in the midline position near the tube so that there's no way to electrify that instrument. That's not an electrifiable instrument. So that makes it very safe because that's usually on the endotracheal tube side. But you see me elbowing that tube so that I can keep working in the pharynx.
Love it. Always think about the subway now. All right. This question is to Ryan Jackson. How many cases do you think you need to do before you get used to the SP?
That's a loaded question because it's probably different for everybody because I think people's brains work differently. And this is an instrument that I think you really have to think about. It's less intuitive than the SI and XI systems were. My first 5 cases, it took me twice as long to take out the primary tumor than it did my prior 5 cases on the SI. And I got really frustrated with it actually because we were one of the early institutions that bought the system. It wasn't that I adopted it early, we bought the system early and our SI got packed up in a crate and sent off. So we didn't have a choice. So I switched to this. My first 5 cases were frustrating. And then I started letting the fellow operate while I was the assistant. And I probably learned more on that 6th case watching the fellow because they were making the same mistakes I was making with the collisions. And it was all about collisions internally. And I talked to Ryan Lee a lot about this on the phone, trying to problem solve these darn internal collisions. So, after that 5th case, I really got an aha moment of why things were colliding and how to avoid it and how to detect that it was happening before it actually happened. So you would see instruments move in the pharynx. You'd see your camera shift and jostle places. You'd see the retractor move without you actually moving any of these things. And it made me pause and move back and get away from that potential collision. So it probably took me another 5 cases to really figure out how to start using my fingers and wrists instead of my elbows to make the system work the way it's designed to work. So probably about 10 cases overall, all because I watched the fellow operate and learned what I was doing wrong.
Chris, what do you have?
A high five.
All good. Just texting.
Oh, you also raised your hand while texting.
Yes, and we have a couple of folks who also accidentally raised their hand, and they're going to text us with any questions in the Q&A. So I just wanted to point out we have people from around the world, from China and from UK at least, and beyond. So a robust discussion tonight on the SP.
Cool. All right. So our next question is for Ryan.
Yeah. So Dr. Sumer, directed towards you. Are you one who typically intubates nasally or orally, or it depends on the type of case that you're doing?
I used to do nasal intubations, but now it's almost exclusively oral intubation. And the reason for that is I don't like to have the tube hiding out behind the soft palate. I like to see where it is in the oral cavity. Now, if it does get in your way, you can, once again, pull it out of the way or push it out of the way using your third arm, which in my case is the cutiere, always in that kind of midline position near the endotracheal tube. That way you're not tempted to grab it and hit the pedal and accidentally burn it. Or you can elbow it out of the way, as I showed earlier, or you can stitch it out of the way. But regardless, I just like to have the tube somewhere where I can find it. And there's no place in the nasal cavity, nasopharynx posterior to the soft palate, for example, where it can hide out. So that's the way I do it now.
That's a good answer. Do you know what type of tube do you use typically?
It's going to be 6 or 6.5 reinforced. Almost always.
Wire reinforced. Okay.
Yeah. I used to use the laser tubes, but I worry about they're all metal, and I don't know if that transmits the cautery. I know it doesn't. It's not going to burn, so it's kind of, I guess, fireproof in a way. But it can, it's metal, so it can transmit that electrical, energy into the larynx, the vocal cords, and things like that. So I do use the reinforced.
That's good. Thanks. Yeah, I think there's probably a decent amount of heterogeneity in what people do. I nasally intubate everybody, but I can see entirely the logic of oral intubation and just being sure of where the tube is all the time. I know Dr. Jackson orally intubates most of his too, I think. But I also agree. Yeah, I also agree with you. A wire reinforced tube is great because you can't kink it, right? And it's very flexible. You can keep it out of the way, and it won't bend and obstruct no matter where you put it. That's great. Let's keep moving.
Awesome. So Fumi, you get to answer the next one, which is the same question, just came up earlier. What tube do you use?
I think Veron stole my thunder there.
Sorry. I'm so sorry.
But I would say that I think, again, just like we talked about, for depending on surgeon preference, if you're going to be doing a nasal intubation, I find that the nasal ray tubes are, they have the pre-bend on them already. They have a good length so that you don't risk your tube sitting in the supraglottis with the intubation, again, for that length reason. And also, you also have the advantage that you're not going to try to bend the tube because the pre-bend makes sure you don't have kinking. It's already designed into the tube. But if you are doing oral intubation, I definitely would agree with using a wire reinforced ET tube because it allows you that flexibility to be able to move it out of the way, and it's not as constrictive or rigid as some of the laser tubes that are available. Now, of course, the laser tubes are coded to be metal or fire retardant, and they're helpful if you're using CO2 laser. But I think for the standard, TORS cases where we're mainly using cautery or diathermy, I think you can do with either of the tubes we talked about.
Agree with that. All right, and so we've got an example here of a nasotracheally intubated patient. I think, Ryan Lee, you submitted this, your standard kind of approach here.
Yeah, my only pearl there is I put a little Miracell, you can barely see it, a little Miracell nasal packing in the nose just to protect the nasal ala. Because as you can see, this tube is, at least the way I'm positioning it, is really wrenching on the alar rim. And so just to avoid some ischemia to the rim, put a little pad there. That's all.
All right, and I agree. I think there's lots of variety there. I will often use just an MLT so it's straight there and stitch it in so it doesn't have that kink back on the nose. And I think this is one where there's a lot of right ways to do this. You just have to figure out what works best for you and it makes you feel most comfortable. All right, but Fumi, we're talking a lot about fire safety. What fire safety measures do you practice when you're doing TORS?
I think the first critical thing for fire safety is to recognize that it's definitely a multidisciplinary issue. And what I mean by that is, as much as we can think of, I have this slide, thank you, that sort of talks about, the different disciplines involved in the case, the circulator or the surgeon or the anesthesiologist and what your roles are. I think everybody has a responsibility at the same time to try to make sure they do everything they can to ensure there isn't a fire in the room. And that starts from, being strong communication, between the surgeon, the anesthesiologist saying, I'm about to start using, cautery, what's my FiO2? If you're doing, some institutions definitely do like specific timeouts for cautery, not just a laser timeout. And I think that's something that can also be considered significantly as well. So this here is sort of what, we may all be familiar with. It's that staging that you might, or the category that you might hear the scrub nurse, or the circulating nurse talk about when they can say, hey, the patient is ASA, fire risk 3. But it basically looks at some of the things that could potentially serve as fuels or ignitions or oxidizers. And this is my reference here. But it just talks about the things that you have to be aware of and what you can do in terms of communication and timeout to try to reduce that risk. You can go to the next slide. So this is, the algorithm that I think is pretty important. I'll just kind of highlight some of the critical things that are on that algorithm. This is from, from the American Society of Anesthesiology. And they talked about, first of all, thinking about prevention, which is where you're going to be, communicating with your team, making sure that any sources of, the fuels or oxidizers are, identified ahead of time and communicating again before you start using anything. And then when you talk about the management of the fire itself, I would say, these are things that are pretty critical for the residents on. This does come out sometimes on your in-service exams, but knowing that, when you have a fire that happens, you want to immediately, this kind of lists steps, but the two things you want to immediately do is remove the tube and stop the source of the oxygen. And then you always want to have, saline on the back table. I think that's pretty critical. If that happens, having wet towels available are also pretty critical. But these are some of the steps here. You want to remove the tube, you want to, stop the flow, you want to remove any sponges or flammable materials, and then just pour it in the airway. People see about a liter to usually do it, and then you basically suction that out and reestablish the airway. Next slide. All right, this is just an interesting article that I came across recently talking about Thrive. And Thrive is, something that it's a modality for ventilation that's coming into the horizon. You may have more, but basically it's providing transnasal humidified rapid insufflation. Basically it's where you give warm and humidified oxygen, you administer it through high flow nasal cannula, and then you achieve ventilation while the patient is apneic. And this was an interesting study that was done where they actually tried to use this in the TLM case, obviously in porcine larynxes, thankfully not humans. But what they found was, if you provide a 30-second continuous CO2 laser firing burst, and you range your oxygen delivery from 21 to 100%, once you get to about and they also did this looking at different materials that are put into the larynx. And so once you get above 30%, which is what we always talk about in the operating room, where we say, FiO2 less than 30 preferable for a case, you start seeing you get more sparks, and sparks are worse than smoke, and fire is obviously the worst that can happen. And you can see that as you increase your wattage on your laser, and you decrease your FiO2 as well, you're going to be seeing more sparks. And essentially this is saying that you can pretty much cause a fire once your FiO2 starts getting pretty high. And just to kind of keep that in mind, I don't see that many of us will be using Thrive initially right now, but I think it was an interesting study that they did in larynxes, porcine larynxes.
That's awesome. Thank you for sharing that. All right, Ryan Jackson, what oral retractor or retractors do you like to use?
That's a good question. I hear a lot of people use different retractors. I use the FK for everything. The reason I use the FK for everything is I can expose everything with it. I don't have to fumble between retractors. I might use different blades. I use the paddle blade for most exposures, probably 98%. I occasionally use the little curvy tongue blade that comes with it for the other couple percent. I never use the slotted blades. I can't fit them between anybody's mandible arch. Because I actually herniate the tongue into the mouth and into the floor mouth. I don't pull the tongue out with a stitch or anything. And I cannot fit that slotted blade in anybody's mouth. So I use the FK for a tonsil. I use it for a tongue base. But that said, I also have FKs. If I only had one FK and I had 2 robotics cases, I would save the FK for the more challenging exposure like a tongue base or whatnot, and use something like a Crow Davis for a tonsil. But the Crow Davis to me does not have enough tilt to it. I cannot retract on it as hard as I want to. The FK, I can really put the suspension arm on it and crank it really hard and lift the patient's tongue and larynx up into the air and create a lot of space. So that's my preferred retractor for everything.
Yeah, awesome. Ryan Lee.
All right, I'll stop chatting. Okay, so quick tips for docking. So again, Dr. Oluwafumi Lola, can you give some of your pearls for just the rapid and efficient docking of the patient cart?
I think the SP makes it much easier to dock compared to the previous systems that we had. And, for maybe some more surgeons like me who have a smaller inertia, I think being able to move this much easily to the patient side is definitely helpful. I always say that, if you properly plan and position, then you can prevent a poor performance with a patient. So quick tips, when we look at this, when there's on the boom for the patient side cart, you have the touchpad, and that would normally display this for you, telling you when you're ready to sort of drape. Here, you can basically hit the button there, long hold for deploying, for draping. This puts the boom into a position where you can allow draping of the vital components. And then the stow will retract the arm and drive into a compact position. Next slide. But for you to actually get the case ready for the procedure, there's an automated deployment, which is one here, which is the button on the left that says deploy for docking. Once you do that, you have to do a long hold. That moves the boom and the instrument arm and the instrument drive into the position. And then whoever is non-sterile can then move the patient cart. They press the patient cart drive, and that steers the patient cart into the sterile field. And then you can then connect the instrument arm to the port. Again, if you need to keep it out of the way, or you want to protect your sterile field, you can basically hit the sterile stow. The button-enabled joysticks, or that function allows you to be able to actually modify and rotate the boom as well while you're trying to get this properly docked. But it is much easier, I think, compared to the previous platforms.
Absolutely, I agree. All right, Ryan Jackson, where do you put the camera and what are you calling these positions? We've got 4 options. We're calling them above and below. What does that mean? And do you use that, or how are you communicating this?
Yeah, I think above and below is fine. Top and bottom's fine. You really need it either above your instruments or below your instruments, even though it kind of curves upward and gets in the way, and it could be above your instruments, even in the below position. So it either has to be on, position 1 or, 3 or whatever. It has to be at 12 o'clock or 6 o'clock. I think I use the top position or the above position for all tonsil work. I feel like I can see everything in that position. I can rest the camera above the anterior aspect or the mandibular aspect of the retractor that's on the tongue without it being in the way at all for a tonsil. So I have zero collisions with tonsils now. For tongue base, it's a little different. You can get by with the top position if you have a direct view of the tumor with your line of sight, because you can get a little backwards flexion of the camera. So you can get about 10 degrees the wrong way. But I just put it on the bottom now for all of them and work that way. I tried that early on because I didn't understand how to use the instruments. Now I work with it kind of like this, where I have the camera in the middle and the other 2 arms next to it that are kind of at the 4 to 5 o'clock position and the 7 to 8 o'clock position, working like this in front of the camera with just the wrists of the instruments and not the elbows of the instruments, because otherwise you hit the camera in the middle. So I'm a camera up for tonsil, camera bottom for tongue base, larynx, hypopharynx.
Awesome.
And just like I think Brittany said, I think it was Brittany, you really got to use the cup of the palate for the camera bottom position. You really want to tuck that elbow into the natural curvature. It gives you an extra centimeter or so of freedom.
All right, these are awesome. Next question.
All right. So again, for Dr. Fumilola, how many instruments do you typically dock? And actually, even more kind of granular, how many uses are on the instruments on the camera? Do you know? If you don't know the answer to this one, I can also phone a friend.
No, so actually, I normally dock for most of my cases if I'm usually 2 mainly, but of course that 3rd arm is very helpful sometimes. But I would say that just as a background for for the audience, these instruments they're described to be like endo-wristed instruments, meaning that they have like 2 joints that kind of work like a shoulder and an elbow, and that just increases your range of mobility that you can work with. Currently, with the latest updates for the SP, because they've had a few updates in the past year, the instruments, you have about 25 uses actually. Each sheet that you put on has to be disposed after each patient, but each instrument can last for up to 25 uses. The camera has 33 uses, and now, of course, it's been updated with Firefly, which is basically your fluorescence capability with ICG that allows you to be able to see the anatomy as well. But that's what I've been able to find out so far from Intuitive.
Awesome.
All right, thank you.
It is really handy because sometimes you get that error and you can't figure out what it is, and you need to know how many lives you have and where to look at it on the screen. So, occasionally it's that your instrument is out of lives. And it's like a video game, you got to get another one.
Yeah, and a little survival tip. I did run into a situation. We have 3 cameras in stock at all times, but you can run into the perfect storm where one is broken, one is at end of life, and you're down to one, and you're risking it a little bit because if that one malfunctions and you don't have a backup, then you don't have a case, right? So I think I kind of set the workflow in the OR asking that the OR staff request a new camera to be shipped to us before end of life of the camera. So for example, with 3 uses left, I asked them to order us a new one so that it's waiting for us. We always have at least 2.
Great.
All right.
Okay. Brittany, can you describe what this camera cobra pose is and how you achieve it?
Yeah, so I was born in the era where you could just simply press the button and it would go into cobra pose. So I that's fortunate, although obviously when you do the training, they teach you how to do it just by flexing forward and then pulling back. I use the cobra pose mostly for base of tongue. I don't really ever use it for a tonsil unless there's a lot of, as I was mentioning in the chat, inferior pharyngeal extension. Then I do find it is useful if you back it up into the contralateral palatal fossa, so it's out of your way. Then I think the cobra pose is useful there. But otherwise, I really simply just use it for base of tongue for the most part. And again, it can be useful if you utilize the palate. Other than that, I find it's not as useful for a tonsil unless there's that inferior pharyngeal extension.
Yeah. So these are the 2 options you can select from the navigator screen. And then I think you had submitted this picture as well. Is that correct? Or Ryan, did you put that in?
I probably put that one in. Yeah. So do you mind toggling between this one and the next one?
Yes.
The point of this one, and lots of the panelists have alluded to this, is that you can see the majority of the length of the instruments are not actually in your visual field, right? There's an elbow joint proximally, and then there's a wrist joint distally. That's really good, Katie. That's awesome. and so if you put the camera in cobra pose, look how much more space you have between the parts of the instruments that you can't visualize and the camera itself, right? And a lot of the collisions happen off screen. A lot of the spaghetti tangling of instruments and camera are off your visual field. So to maximize that spacing, as well as relying on the navigator, I think it is very helpful if it's feasible and you have enough working space to put the camera in cobra pose, but also to put your instruments in flexion, as opposed to working with them as straight shafted instruments like you would in for example, a suspension microlaryngoscopy procedure. These weren't meant to be used line of sight as straight shafted instruments. Okay, back to Dr. Sumer. So which instrument drives do you tend to prefer for a palatine tonsil tumors and for management of tongue-based tumors?
So my instruments are it depends on the right and left-hand side. It's always the same instruments for base of tongue as well as tonsils. For fire safety, once again, I always use the Cartier forceps in the midline position. So that's always going to be kind of medial. And then my monopolar spatula tip cautery is always going to be on the tumor side. So this is kind of like a throwback to the SI days, when you had 2 hands and 2 instruments and you kept the cautery towards the tumor side. So that's how I started, and that's just kind of how I've continued. And then I always keep my fenestrated bipolar in the kind of inferior position. So, anatomically speaking, inferior or anterior position. And my camera is always in the superior position. And I find with that instrument configuration, I can get at everything except when you're making your medial cuts. So those are the cuts that are difficult to make. And sometimes, I'll feel compelled to switch the instruments. But a lot of times you don't have to do that, especially if you take your camera, slide it all the way posteriorly in the cobra position into the posterior pharynx, and then slide it all the way to the contralateral side. So for example, for a left-sided base of tongue cancer, when you're making your medial most cut, if you take your camera, slide it all the way to the contralateral right-hand side, you have room to get your left arm in there with the monopolar spatula tip cautery. And if that doesn't work, you can always switch the arms. So that's the instrument configuration I use. And the main kind of thought behind that is I like wide gripped instruments. So that minimizes the tissue tearing and ripping. I tend to think that they have a little bit of a better grip, and that's the Cartier and the fenestrated bipolar. And then the other thing is, because you have width to your wrist, you can actually wrap tissue around your wrist. So sometimes I'll grab tissue and rotate it clockwise or counterclockwise, depending on the configuration, to wrap that tissue around my wrist to create stretch and traction without having to move the entire arm, which can sometimes get into view of your camera. So there's some nice things, nice features about using the wider instruments as well.
Awesome.
That's a really great tip. Yeah, on different little tips and tactics to generate more tension and traction, counter traction. Absolutely. Thanks.
This is sort of an add-on. So you may have largely answered this question, but when do you use the third arm? Are you using it all the time, or just when you can get room? Doesn't always seem like you can get all the room you need. Do you use it every case, or what are you doing?
I use it every case, but not all the time. And I don't feel obligated to use it. So just because you have a third arm, you know, I don't feel like I need to use it. But I do like there are situations where you realize, wow, having a third arm is awesome, especially if your assistant can't get two hands in there. So you've sort of a lot of times lost one hand of your bedside assist because there's just no room for them. They can only get one suction in there. But in my mind, it's an even trade-off, or a better trade-off, because if your assistant at the bedside is not experienced, for example, and they're not providing the perfect counter traction for you in a given situation, or they just can't get there, you can do that for yourself now with your third arm. And there's a lot of things you can do with the third arm.
Sure. All right, and you have a couple of videos here, I believe.
Right, so this is one example of using it for counter tension. So you grab the tumor and you pull on it, but then you can provide counter tension with your other arm, freeze that into position, continue your dissection, and then, you know, grab deeper, and then provide more counter tension for yourself. So I don't know if these videos are coming through, but that's one way of using this. The other way is retracting it. So you can grab the tumor, retract it, and then use your other two instruments to sort of continue the dissection while you're providing a fixed retraction with your third arm. So that's another way I like to use the third arm.
And I'll point out that you're using the monopolar curved scissors as a hot scissors there, which is a really, you know, it's something that many people on the call may not have seen before.
Right. And so this is kind of an early case. So you sort of see the key towards the left-hand side that shows you what I'm using. So superior is towards the bottom there. The camera is in the superior position. And this is kind of an older configuration. This is like one of my earliest cases. That's why I have the monopolar curved scissors. I abandoned using that. That's the only instrument I had available early on. And I stopped using that mainly because the tip is pretty sharp and it creates a lot of char on that tip. So the only times I'll use the monopolar curved scissors are now to cut through bone or cartilage, because you can't bovie through those. Or if you're doing like a supraglottic laryngectomy and you want to do a very precise cold cut into the ventricle between the true vocal cord and the false vocal cord. Other than that, I don't really use the curved scissors too much.
Yeah, it's hard to clean them off, but they do take a nice margin.
Yeah.
I think this is the same one.
Right.
Okay. And then this is the last one. This one's cool. Here we go. There's another use of your third arm.
Oh yeah, you can use the third arm for suctioning. So I want a suction in there, right? So this is a patient who's got a very tiny hypopharyngeal cancer in the postcricoid space. There's some blood there because you know, it's just there. And so what I do is I put a red rubber catheter in the nose, hook it up to a suction. Not only does that suck the smoke and get rid of the smoke, but it also allows you to sort of, you know, suction away blood and use it as a suction. And then this is one of those examples where you can change the settings at the bedside, at the console. And this is me using auto cut on a very low setting of 1, because you saw the nerve to the cricopharyngeal soft, the recurrent laryngeal nerve there, and you obviously don't want to damage that nerve in that area. So this is a very, very precise instrument when used that way. And then, you know, you can always use the fenestrated bipolar to stop any sort of residual bleeding in that area. But I love using it as a suction.
That's awesome. All right. I'm going to go ahead and skip over this one so we can get to all our questions.
Okay, so Dr. Barber, how many instruments do you energize when you dock?
Yeah, I have to say I very rarely use the third arm, to be honest. So I'm almost always just using the two, but I like to just use a Maryland and a Bovie and the bipolar Maryland. If I'm using a third arm, I use a fenestrated bipolar. Though again, I just don't find that I need to use it that often. So.
Thanks.
All right. Brittany, any tips for preventing collisions? We've talked a lot about it, how much people don't like it. How do we avoid it?
Yeah, so I would say that probably some of the things that have been said previously are good points. So I think I keep harping about this. Just backing your camera up into the palatal fossa is always really helpful. I think that placing the camera against the retractor or just in front of the retractor when your camera's on the top, so that you have awareness of where it is, and then curving your instruments out with your elbows out to really bring them far away from your camera to avoid collisions that way, keeps you from sliding over top. And then I think other than that, again, utilizing the kind of contralateral palatal fossa to keep the camera out of the way can allow you to bring your instruments over top to get down into a corner or down into the inferior pharynx. I think those are all really helpful tips to avoid collisions.
I think getting up and going up to the head as often as you can whenever things aren't working right, so you can try and figure out what's going wrong. Ryan, I'm guessing you submitted these with a little.
Yeah, I had to throw something in, right? So basically, this is a photo from a snapshot from an actual surgical view. So you can see, you can't see the wrist joints and you can't see the elbow joints here. You never see the elbow joints, but the wrist joints are not visible. And you can picture, this is a left palatine tonsillar mass. So easily the left-sided instrument can collide with the ramus of the mandible and the third molar. And the right side, if you're retracting far enough to the right, can also collide with the lateral bony structures. So can you jump to the next slide?
Mm-hmm.
Thanks. So then here's somewhat of an alternative. If you're trying to retract, for example, the left palatine tonsil to the right, the hash marked lines, so those dotted lines, are kind of the intuitive or the natural way you would probably want to pull with your hand. Okay, you'd kick the wrist joint out and you'd retract to the right. But one way to kind of minimize collisions with the mandible and the third molar is just to kind of bring it doesn't feel natural initially, but bring your wrist joint in more immediately towards the center of the screen and just push the tissue to the right. And you can actually generate more tension that way. I learned this actually from a urologist because they were very frustrated when they first adopted this system and how much tension they could generate. Okay. And then lastly, just think about when you're operating, again, that it's not meant to be operating with instruments in a kind of straight shafted orientation. They're not meant to be line of sight, right? So there's lots of ways you can see the tips of the instruments better. If you click one more time, Katie. Thanks. The bottom right image is just essentially flexing all the instrument wrists so that they're facing posterior or heading towards the posterior wall. It keeps you in a narrow operating field, keeps your instruments from colliding with the mandible, but also allows you to see the tips of your instruments too. So just a reminder that use those flexions. And then this is just a little drill I did with the fellows. I'm not sure they liked it very much, but this is really just giving you an idea again. If you were to able to see your wrist joints, and if you pretend that that gray ring is the mandible, how easy it is to collide with the mandible when you kick the wrist joints out laterally, which again is a very natural movement to make. So what you could do instead is bring the wrist joints in like this medially and pull or push the tissue out laterally. And you can generate a lot of tension and have a lot more working space because you're not kicking the wrist joints, which are large, out towards the third molar or towards the ramus. And that's it.
Awesome.
All right, back to Dr. Sumer. Do you use the finger clutches at the surgeon console or do you use the pedals to adjust your instrument or your hand position?
Always the finger, and that's just what I'm used to from the SI days. And I actually had one question for you, Ryan. When you were showing those videos, is your camera in the kind of the superior position or the inferior position?
For the snapshot?
Yes.
That's a good question, actually. I'd have to go back and take a look.
Yeah. That was really cool the way you described it. I really liked the way you described the kind of the tension and the forces that you're applying there. But it looked to me like maybe you're in the superior position, which
it looks like I am. Yeah.
That's great. Yeah. So that's very helpful.
Typical for the tonsils. Yeah.
I use but just to answer your question, I use the finger clutch just out of habit, and I find it easy to do.
Good. Great. Okay. Thank you.
Similar question. you have the history of having had the focus change on us as we transition from SI to SP. Can you talk to us a little bit about this autofocus versus our manual camera focus? Has it impacted you at all?
It has not impacted me at all. It's actually very good because the depth of field is actually very it's very long. So it's got a long focal depth. So it doesn't really come into play unless you're super close or not. So this is a case of a patient with an unknown primary who had like these massive tori. So I actually couldn't get far enough away from the left base of tongue to actually look for this thing. So I actually angled the camera. If you look below where I'm kind of highlighting that, you see you can angle the camera for access. So your anterior posterior distance is fixed by the fact that this patient has tori that limits, makes the mandible essentially, for all intents and purposes, smaller. But if you actually tilt the entire thing at a 45-degree angle, you can back the camera away from there and get a little bit more distance between yourself and the tumor and look for this tumor candidate here. Now, this was the only case that I had to do this, right? So this is the only time that I've really had to do this, which tells you that the focal distance that you have is very, very workable and very nice, and you're able to use that for most things. But this was just a very, very bizarre case, which kind of goes to show you that unless you're like operating at the extremes of anatomy, that focal distance is really nice, and you don't have to now mess around with setting the focus by rotating your wrist and trying to adjust it yourself. I actually really, really like it, and the camera's super high def, so the view that you get is much, much better than you do with the SI.
Awesome. All right, Ryan.
Okay, Dr. Fumi. So tips with using the navigator, which I think we're all learning how valuable it is to have that for orienting ourselves. But there's a frontal view, side view, and there's a overhead view as well. What do you prefer and why?
Right. So I think just as a background, the navigator is that graphical interface we're referring to that sort of shows the relationship of each instrument to each other and to the other instrument basically in real time. You can usually get to it through the surgeon console, or it's also on screen. But I think, for me, I prefer the top view. You could go to the next slide. This is just like just showing you the options you have. So you could have a front view, which is on fast. You could have a side view, or you could have the top view. I like the top view because conceptually for me, and this may just be me, but it gives me the same view that I'm sort of seeing looking at my instruments while I'm operating. And that to me is it's conceptually makes more sense to me when I'm operating. The front view is also great. I think that especially if you're trying to look at or conceptually understand the cobra pose, I think that's one way where you can sort of look at that too. But I think, I don't usually use the side because again, conceptually for me, it just makes more sense to look from the top. I'll be interested to know what other people think as well or use.
I use the side because I think that my biggest conflict is I can see my biggest conflicts with my camera and my instruments that way. And so for me, that's been helpful to try and avoid those collisions. I think that maybe if everybody can put what they do in the chat, we can get a consensus. The next one is for Ryan and I. For those of us who previously used relocate, so this was the big beeping noise where the whole cannula will shift, and so this was really made for open surgery. And I think I don't know. Did you ever use it, Ryan? Lee, did you? What did you?
Very limited use, yeah, because I was always had intuitive in the back of my head saying, don't use it in the oral cavity or pharynx, things, there's too much shift of instruments.
Yeah.
So,
same. Yeah. I would use it just a little bit if I felt really comfortable where everything was, and I just needed to make a little
exactly
shift. I would finally go up to the head, but it's no longer there. So if anybody tells you to relocate out there in our audience, you can't do it anymore with the new system.
Yeah, I assume the pedal has been removed from any old system too. Yeah,
I would imagine so.
Okay, Ryan, Dr. Jackson, any kind of pearls of wisdom for how to manage your surgical assistant with as little profanity as possible,
I was gonna say, since it's usually a
Kindness and love.
it's with loud cursing and throwing instruments, but no.
Okay, we can move on then. Good.
No, I think this is, like I said earlier, this was one of my biggest challenges, was getting a resident to be able to do this. And the way I think of it is kind of like a Mission Impossible movie or some movie where they're trying to steal something from the vault and all those lasers are going through, and you got to try to somehow do these backflips and dive through these lasers in a multi, dimensional space to get to a linear instrument through it. It's very challenging. So the surgical assistant has to be very aware of the angles they're coming in. Either it's from the right or the left. You don't want to put your clips on straight on. You kind of want to come in from the side. You don't want to put your suction straight in because you're not going to get it to where you need it. You kind of have to either come above your instruments or below your instruments to angle upward. And then they also have to be aware of, maybe sometimes they need to straighten one of the instruments out for you because the elbow is just too far in the way. They can't get a straight clip applier in there. The problem with that is you don't want them to pull out the instrument that's holding the blood vessel or controlling the bleeding or retracting to get you the view. So they have to have some awareness. So there's a lot of communication with the assistant, much more than there was with the SI system in my experience. Plus my involvement as the console surgeon, or the fellow's involvement as the console surgeon, is much more hands-on as the assistant. So I just stand up and turn around and the head of bed is right there. I park myself as the console surgeon very close to the assistant. So all I have to do is stand up, the instruments are parked. I can go over and help them problem solve, tell them what instrument to pull back to straighten out so they can put a clip on, yada, yada, yada. So it's more of a team sport now than it was before. It was kind of me working independently, them working independently, just knowing intuitively how to make the system work. Now it's much more communication and teamwork.
Yeah, I feel like finding the right words is really important to try and explain to your system where you want it to be.
Mm-hmm.
Brittany, how about vascular clips? We've heard a little bit about the bipolar, but are you still clipping things? What are you clipping? How do you clip them?
Yeah, so I don't use clips nearly as much as I used to. I used to use them for a lot, but with the bipolar, I think that a lot of that has gone away. I will still use clips on the dorsolingual and a fairly sizable ascending pharyngeal. I don't quite feel adventurous enough to bipolar that just yet, though I know some people will say it works just fine. But yeah, so I've really gone away from using them. And I also find that when patients go home and they see a clip in their mouth, they'll comment on it. And so I think that's another thing, but mostly the bipolar, I feel pretty comfortable. All pharyngeal plexus vessels and anything that isn't a major named artery, I'll use that for.
So I think this is an important point that we want people to take home, though. Anything that's like maybe over 2 millimeters, something that has a name, might deserve some metal on it, especially as we're trying to avoid those bleeds. But I think that's great. Wouldn't you like it if there was a articulating clip applier?
Someday.
That would be great. That'd be great.
Yes.
Coming soon. Okay, so how about managing recoverable faults? Have you encountered that? And I guess I should explain that. So sometimes you'll be operating and all of a sudden the machine makes a noise and you can't keep operating. Either it's a irrecoverable fault and the thing shuts down, or it's just a recoverable fault and it just pauses and you can't keep moving until you fix it. What do you do in that situation? Kind of walk us through, for someone new to the SP, what that looks like and what you do.
Yeah, so I mean, this is a loaded question. I'm sure lots of people have their algorithm for this. So I would say most of the recoverable faults are going to occur before you get started. And so the things that I always double check, 80% of the time it's the drape, because the drape needs to be clicked in appropriately. And so if your arms don't click into that drape, or the drape is not quite clicked in, then your arms will be inactive. And so it will show you that it's yellow instead of blue like you want it to be. So checking all the drape clips first, and then also checking the magnetic drape attachment on the top beam of the robot is important as well. That will also kind of trip you up. The other thing, I'm sure everybody's experiencing a lot of traveler nurses that may not be familiar with the platform, and so I'll find that I have to kind of double check that drape multiple times, and then also double check that the everything is plugged in exactly where it should be and actually plugged in and not just not unplugged, I guess. You can't plug the wrong plug into the wrong instrument, so that's fortunate. But I always have to double check those things. Another one is the arms being expired, because that's something that doesn't always get checked, especially if they don't have familiarity with the platform. So if everything else is working and that is not, then checking the expiration date or the number of uses on the arm, I think is important. And it won't let you start unless you have done that. Sometimes it'll be that the camera is put in the wrong slot on the scope holder. So if you don't have the camera in the camera slot, you can still put it in one of the other slots. So that is always possible. You have to make sure that the camera is in the right slot and that it is in the camera slot, basically. And that the scope head is for sure plugged in. It should show you kind of an error message, or you should get a green if it's not plugged in, a blue if it is working. And I've had that happen before as well. And then other things like the sleeve not being completely on the camera and them having to readjust that sleeve, those things as well. I've had very little recoverable faults while I'm actually operating. I can't say that that has happened to me a ton because the system is pretty robust for avoiding that where that was a little bit more common with the SI. So I can't say that I've had a lot of issues happening while I've actually been operating. So I guess that's fortunate.
I think that there were some sort of funky bugs early on. I agree. I think a lot of those have gone away. If you do get a fault, though, it'll give you a number. And if you can't figure out what it is, if you write the number down, when you call Intuitive, you can tell them what the number is and they can look it up and try and walk you through how to fix it. That's my tip. Ryan, I stole your question, so you can ask the next one.
I'm just devastated. Yeah. No, and I was going to add on to what Brittany just said too. So you may not have noticed it, or maybe you have, the Megadyne pad. If any of you use Megadyne pads, which allow you to ground multiple instruments on a single grounding pad, it doesn't work with this system. At least the last time I checked it, it still doesn't work. You have to ground with individual grounding pads, the little Covidian or whatever grounding pads you use. Somebody can correct me if I'm wrong, but that was it's a problem. It's not always clear that that's a problem. You just will find that you can't cauterize. You can't deliver energy with the instrument. Okay, so Dr. Jackson, we do, and by the way, everybody, we're very close to the finish. I know we're a little bit over time, but there's only about 2 or 3 more topics to cover, okay? So what do I do, Dr. Jackson, if I don't have an SP? Do we just send them all to you?
Yeah, that was going to be my answer, actually. I think WashU will buy your patient a plane ticket, just fly them out, we'll take care of them, and then buy them a plane ticket back. I think Intuitive sponsors that actually too, but no, it's challenging, right? And I think a lot of it's going to depend on your hospital system and what your rules and regulations are institutionally about how you manage non-FDA approved devices for surgery. At my institution, it's not a problem. So, if I had an SI, I would use the SI. If I have the SP, I would use the SP because both are FDA approved. With the XI, I would use the XI for whatever I can use it for because we don't have those limitations at our institution. We don't need an IRB for that either. So I think you would have to navigate your own system, whether that be you do this off-label and just do it off-label. That's fine. I take out T3 tonsil tumors. Those are off-label with the SP. At my institution, that's okay. If it's not okay at your institution, you would have to see if it's okay under an IRB protocol and just have patients sign consent that, hey, the system XI is not FDA approved, but SP and SI are. We don't have those because we're not spending another $2.5 million on one. Are you okay using this instrument? Just have the patient sign an IRB. So I think it's very institution dependent.
It absolutely is. This is not a federally or state regulated decision to make. So just inquire with your policy within your institution. And on that note, so the XI system, I've never used it outside of the lab for TORS, but there are some institutions that actually have done a great job with this. University of Utah comes to mind. They've had an XI for a long time. I don't know if they have an SP now, but they had it for XI for probably the better part of a decade, and were perfectly comfortable with it. Really didn't have any interest in transitioning because they didn't need to. They did a good job with it. But so there are other options.
Awesome.
Yeah, go ahead.
I'm going to stop our sharing. We probably could answer a few questions, although I think that some of those were answered very nicely in the chat. I think I can speak for all of us that it's been a learning curve. There are many ways to do this. I think for most of these questions, each of us could have given a slightly different answer. And I also think I can speak for most of us that we'd be happy to take questions. And if you need a way to reach out to us, you can reach out to our AHNS staff and they can put you in touch if you have specific questions. But really want to thank everybody for the active participation. The chat was robust. I couldn't keep up with it, but everybody else was kind of handling it a little bit. And it's really very fun to hear from so many wonderful colleagues from across the country. So if anyone else has any comments, we can take them, but otherwise we'll let everybody get home for the night.
Well, I want to thank Ryan and Katie for your leadership and our amazing panelists for their insights. I learned a ton, and we're going to have another TORS AHNS webinar starting in the new year. Scott Magnuson and Julia Crawford are going to talk about transitioning from fellowship to practice, and Scott's going to talk about TORS in the real world, if you will. So with that, I'll bid everyone good night, and I got to give a virtual and real round of applause for her. This was amazing. You guys what a great conversation tonight. So, and
thank you to Oshun for all the work you did behind the scenes too. Really appreciate it, and Chris as well.
Yes.
Thank you.
No, it's all Oshun.